Why can't we give COPD patients high flow oxygen? And more specifically, why can't we give chronic CO2 retainers high flow oxygen? Well, it comes down to two effects: the Haldane effect and hypoxic pulmonary vasoconstriction. Traditionally, it was always taught that COPD patients who are chronically acidotic rely on something called the hypoxic drive. CO2 is better at diffusing than oxygen and forms carbonic acid that reduces CSF pH and stimulates central chemoreceptors in the medulla oblongata. High CO2 and acidosis drive faster and deeper breathing patterns. However, in patients with COPD, it was previously thought that chronically high levels of CO2 desensitized their chemoreceptors, and to compensate for this, oxygen receptors in the carotid and aortic bodies are used to detect when respiratory effort needs to be increased. And therefore, by giving high flow oxygen, you're losing this hypoxic drive. However, this is not the full picture, and there are at least two other pathways that have a more significant impact than the hypoxic drive, and they are pulmonary vasoconstriction and the Haldane effect. These are both physiological processes that can turn pathological when high flow oxygen is given, and we'll start with the Haldane effect. Oxygenated blood contains a lower CO2 content than deoxygenated blood. Oxygen binds to hemoglobin, hemoglobin offloads CO2, this forms carbonic acid in the blood that is then buffered by bicarb to form HCO3 and H+-, that then, with the help of carbonic anhydrase in red blood cells, is converted to water and CO2 that is then exhaled from the lungs. This returns the pH to its normal level. This is a physiological process. However, in chronic CO2 retainers, they already have an elevated level of CO2 in the blood. When you give high flow oxygen, again, the oxygen binds to hemoglobin and the CO2 level in the blood increases. However, this time, the kidneys have already maxed out their compensation by retaining bicarbonate, and the CO2 cannot be effectively exhaled due to a patient's poor ventilatory capacity. So, you get an acute on chronic acidosis and a lowering of the pH. Well, what does this result in? It results in all the effects of acidosis. You get myocardial depression, you get a raised ICP, because CO2 is a powerful vasodilator, and eventually you'll get hypercapnic encephalopathy. So why don't we see a respiratory rate increase? Well, raised ICP and hypercapnic encephalopathy directly cause respiratory depression, therefore further reducing how well CO2 is exhaled, and it becomes a vicious cycle. The next effect is hypoxic pulmonary vasoconstriction. In normal physiology, areas of poor ventilation in the lung, like you see on the right here, have lower ventilation and they have reduced blood flow due to vasoconstriction. This diverts blood to areas with good ventilation and preserves ventilation perfusion matching, or VQ matching. However, in pathology, you get high flow oxygen going to both the poorly ventilated and well ventilated regions. This loses the vasoconstrictive stimulus, so the poorly ventilated areas now have lost their vasoconstriction, as you can see here. So you get the same volume of blood going to both the well ventilated areas and the poorly ventilated areas. So you lose VQ matching and you get an increase to the CO2. Together, the Haldane effect, causing acute on chronic acidosis, and hypoxic pulmonary vasoconstriction, meaning that they have a reduced ventilatory ability to offload CO2, work together to worsen CO2 retention. This is true, however, only for patients that are chronically CO2 retainers, with the characteristic low or normal pH and a raised bicarbonate on VBG or ABG. indicating a metabolic compensation. If patients are not chronically acidotic, even if they still have COPD, they will have the physiological reserve to deal with the Haldane effect, and they won't have the vasoconstriction due to poor ventilation in the lungs. And in these patients, high-flow oxygen is significantly beneficial, and it's important to remember that hypoxia kills. So in these patients, you need to set that target at over 94%.